Hi, I am Raquel and I am excited that I get to talk to you about a case of acute hypernatremia due to polyethylene glycol with electrolytes. First, let's discuss why is this important. Acute hypernatremia is characterized by rapid elevation in serum sodium levels that occurs within 48 hours. This could be dangerous for patients. Acute hypernatremia is most often due to salt poisoning or diabetes insipidus. Conversely, chronic hypernatremia, which is more frequent, is usually due to unreplaced water losses. Cases attributed to bowel preparation are infrequently encountered in clinical practice. To my knowledge, there has only been one case report of hypernatremia due to polyethylene glycol poisoning. Now, let's talk about our patient. She's a 22-year-old woman with cystic fibrosis who presents with 1 week of worsening abdominal pain, constipation, vomiting, and an inability to tolerate oral intake. She was admitted and diagnosed with DIOS, which stands for distal intestinal obstruction syndrome. DIOS is an acute, complete or incomplete obstruction of the ileocecum by inspissated intestinal debris. Think about it as the adult form of meconium ileus that occurs in babies. Treatment consisted of continuous LR infusion and administration of polyethylene glycol with electrolytes and ascorbic acid via nasogastric tube. By hospital day 2, she was clinically improved with clear stool output and decreased stool burden on repeat abdominal X-ray. However, she became progressively less responsive throughout the day. Other than cystic fibrosis, she also had pancreatic insufficiency, prior episodes of DIOS, mild obstructive lung disease, seizures, depression, and these are her medications. Physical exam was notable for tachycardia and tachypnea. Over the last 24 hours, she received 3.3 liters of Plenvu, 1.6 liters of lactated Ringers, urine output was 1.6 liters, and she has had 8 bowel movements. She was obtunded with minimal response to nauseous stimuli. Subsequently, she had a tonic-clonic generalized seizure that lasted less than 5 minutes and resolved spontaneously. Laboratory evaluation demonstrated acute, severe hypernatremia with a serum sodium of 189 up from 139 24 hours prior. Her urine osmolality was 780 and her urine sodium was 300, ruling out diabetes insipidus. The measured serum osmolality was 380 with a normal osmolar gap of 5. She had an acute kidney injury with a hyperchloremic and a high anion gap metabolic acidosis secondary to ketoacidosis, given that her lactate was normal. She also had normal toxic alcohol levels. There was no acute intracranial abnormality with normal volume and gray-white matter differentiation by CT of the head. No signs of bowel perforation or pneumatosis intestinalis by CT of the abdomen. She had dilated and fluid-filled large bowel, likely related to recently administered bowel prep. Her electroencephalogram was consistent with diffuse cerebral dysfunction and encephalopathy, but there were no seizures. Now let's go to our discussion. Hypernatremia is a problem that is commonly encountered by general internists, and after ruling out other diagnoses, this case illustrates that the administration of large volumes of polyethylene glycol with electrolytes and ascorbic acid could result in acute hypernatremia. And although the hypernatremia seen in this patient is a quite rare side effect of bowel preparation, we calculated that the sodium load she received could explain the case as follows. First, we calculated the total body water for a female adult using the Watson's formula. The total body water in our patient is 29.6. Second, we calculated the estimated sodium deficit required to increase sodium from 139 to 189 by multiplying the total body water by the difference between our end sodium, 189, and our initial sodium, 139, and the result was 1,480 milliequivalents of sodium. Lastly, we calculated that 3.3 liters of Plenvu that our patient received is equivalent to 1,596 milliequivalents of sodium, which could explain our clinical scenario. Normally, we would avoid rapid correction of chronic hypernatremia to prevent cerebral edema. The reasoning behind this in chronic hypernatremia is that the initial response of hypernatremia is osmotic water movement out of the brain cell with resulting shrinkage of these cells. Within a couple of days, we adapt and our brain volume is largely restored with water movement from the CSF or cerebrospinal fluid into the brain and also the uptake of osmotically effective solutes by the brain cells. Rapid lowering of the plasma sodium concentration once you have adaptation could cause cerebral edema that can lead to encephalopathy and permanent neurologic damage or death. There's an image on the right that is consistent with cerebral edema. As you can see, there is loss of the gray-white matter differentiation. Ultimately, it is critical to understand that the goal of treating acute hypernatremia, such as in our patient, is to normalize serum sodium rapidly, given that such patients have not had the time to adapt. Thus, we want to restore normal serum sodium within 24 hours. Coming back to our patient, she was transferred to the intensive care unit for close sodium and neurologic monitoring, and her acute hypernatremia was aggressively treated with dextrose 5% in water. On day 3, which is the next day, her sodium improved to 143 and the patient's mentation was pretty close to its baseline. On day 10, the patient appeared well and she was discharged home with no neurologic or metabolic derangement. Here are some of my references. And thank you for taking the time to listen to my presentation. I am ready for your questions.